I have a history in the family from amyloidosis. My father had it, and 5 of my uncles and 1 of my aunts had it, and 2 great uncles that we think had it. So I was very, excuse me, I was very familiar to what to be looking for.
It took about 8 years to get the diagnosis of amyloidosis, and he saw about 14 doctors before he got his diagnosis.
About 5, well, it took her 5 years to get it diagnosed, right? Then once she got it diagnosed, she knew what it was, right? After that, they had me take the fat pad or get tested for the gene. And at the time, I didn't expect any because I had no symptoms at all, right? And just think, okay, let's see if I have the gene or not. And lo and behold, not only did I have the gene, they found that it was active in me. And so from there, it's been, it's progressed up to right now up to my ankles. So it's something that I have all the time.
When I was diagnosed, I was in heart failure, liver failure, and kidney failure. And I was on dialysis.
So it got to a point where we just got a real soft rug, and I spent many nights, I just slept in the bathroom so I could get 5 or 6 minutes of sleep.
It was kind of, you've been to all these doctors, what are you doing here? And I said, we're kind of looking for a silver bullet. And he said there's no silver bullet.
We need something that will at least, if not a cure, will at least improve our quality of life. Whether it's neuropathy, orthostatic hypotension, whether it's bowel issues, whether it's kidneys, eyes, whatever. But whatever it is, it may be a combination of things, but at least improve the quality of life.
I think that the criteria shouldn't be as rigid as it is in some of these trials, because all patients are different. Every organ is, you don't know what's going on in your body, what organ's getting affected. That's one of the worst things about the disease.
I think I got a placebo because I got worse. I went from walking to walking with a cane to using this.
The transplant I did in 2002 worked very well. There were a lot of risk. My heart was involved heavily. Still, I took the risk of the transplant because otherwise they were giving me 6 months to live, and at 53, that was very hard to accept.
It's so strange conceptually because it really is a terminal illness at this point that nothing feels risky.
Knowing my history, my family history, that was a no-brainer for me. I'll go on any trial I could possibly can. I know it's not going to help me. I feel I'm beyond that point, but it will help someone else.
I went from a point of really not wanting to be here, and my main thoughts at the time for going into a drug trial was to save my family, not me, to a point of where I feel good. I'm glad I'm alive. My quality of life is 6 times better, and it's exciting to tell them, if you guys approve this and if it's working, my family won't have to go through this. The second they find out they're starting to manifest, maybe a little diarrhea, they take this drug. They don't have to go through what I went through. You don't have to hit bottom and work your way back. So I'd like to tell them, man, prove this drug, it works, I'm proof.
I know that I am good enough right now, and I can live my life, but I need to get something that's going to prevent this thing from progressing, and time is what is so critical to me.
Having this disease is like standing on a cliff, and you know that the cliff is deteriorated, and you're standing close to the edge. And you know that eventually this cliff is going to drop because it's dropped on others before you. You know that wave is coming. And time is running out. Every second, time is running out for us. It's running out for our children. It's running out for our grandchildren. As that clock ticks, we need something. We need a protocol. We need doctors to come together and for them to listen to the specialists in the field on how to better treat this disease. Some kind of format to go than people that have to wait years and years to get diagnosed. We need better education. We need some hope. And if any of those drugs can improve our quality of life, why would you withhold that? Then watch somebody live a hellacious demise. That's what we need. We need hope.
I have a history.
Perhaps. It's on now. Well, I want to begin by obviously thanking the patients who contributed to the making of this film, focused on transthyretin amyloidosis, which is our focus this afternoon. The Spanish philosopher Ortega y Gasset said notably, "The radical meaning of life is in biography, not biology." I would argue with him because the radical meaning of life is in both biography and biology, and that is the theme of transthyretin amyloidosis. We're very fortunate today, this afternoon, to have the continued involvement of the FDA. They want to hear your voices, and I'd like to ask Dr. Ron Farkas and Dr. Dev Jalopoli to join us on the podium, please. Thank you both very much for coming here this afternoon. We're going to begin, once again, with stories. We're very fortunate to have three extraordinary individuals who are going to tell us their stories. We're going to begin with Dawn Gimble Meyers.
Hello, and thank you for hearing my story. I am genotype positive for familial amyloidosis, TTR CIS114. I feel like it should be tattooed on my body. With the help of family, we have been able to trace this disease back 5 generations, and as far as we know, starting in the late 19th century to today, 17 people have been identified as having amyloidosis or carrying the gene. The only ones that have survived past 56 are those that detected the disease early and quickly received a liver transplant. I have watched my maternal grandmother, my uncle, and my mother deteriorate as this disease devastated their body and cruelly took away their independence and dignity. My grandmother was the glue that held our family together. After her death, rifts within the family arose due to grief and stress of caregiving. These rifts became ultimately fatal for my mother and my uncle as communication of symptoms, disease onset, and medical treatments were not shared. No one in my immediate family has lived past their early 50s without a liver transplant. I was my mother's only child and caregiver. She was 46 when we could see the first apparent symptoms. And over the 4 years, we went to a multitude of specialists. The common thread with each was confusion and lack of information. A referral for a liver transplant did come after visiting Boston University in 2001 when she was 50. However, when the time came for a surgery consult, her body was so overcome with amyloid that she would not have survived the stress of a liver transplant. During the last year of her life, we visited the ER at least once a month, either from a seizure or a UTI so severe it would cause incessant vomiting. Her motor and cognitive skills deteriorated rapidly, making her bedridden. She died at 51. The financial strain of caring for my mother depleted their retirement savings, my parents' retirement savings. My mother never got to meet my now husband, see me get married, or stand joyfully with me as I became a mother. As for me at 44, I'm trying to figure out what is my new normal. Within the last month, my hands and feet have begun to tingle with neuropathy, and despite a negative tissue test for familial amyloidosis, I can't help but feel that this disease is active in my body. This year I plan to return to work after staying home with my children for 8 years. Instead, I'm off to doctor's appointments. I've enjoyed a very active lifestyle. Like yourself, I am an avid cyclist. There's nothing better I love than going downhill with the wind in your face. Within 1 month, this has come to an abrupt end. I don't know how fast this disease will progress in my body. I have 2 young children, ages 6 and 8, and I want them to have a long and healthy life with me. I want a long and healthy life with my husband. I want our memories together to be those of a healthy mommy and not a sick and dying mommy. I have hope. There is promising work in clinical trials. Drugs shown to eradicate amyloidosis, drugs shown to be safe. I am absolutely willing to risk receiving a placebo, but why should I have to wait? And why should I have to wait till I get very sick to be accepted into a clinical trial? Early access to these drugs will guarantee my longevity and make all the difference for my health. I need a better solution for myself and for my family. And this is a quote from my husband at home watching his favorite movie, Shawshank Redemption. Hope is a good thing, maybe the best of things, and no good thing ever dies. Thank you.
Dr. Farkas is from the neurology division at the FDA, and I think it's very, very important to hear these stories about hereditary transthyretin amyloid since he's involved today. Amy Feinberg, please come and tell us your story.
I want to be blunt for a moment and speak to the FDA, to the esteemed doctors, and to our pharmaceutical companies. I am literally dying to meet you. And what I want from you is to make that statement not true. I'm 46 years old, and I am unsure of our family history so far. My father has, this past week, gone for a test. This came out of nowhere for us, and we're waiting to find out. We can't think of anybody in the past 3 generations that have had these sort of symptoms. So I guess there's a very slight possibility I could be a spontaneous mutation, but hopefully in the next few weeks we'll be able to determine that. My early symptoms, at least 4 years ago, were small fiber neuropathy in my feet and shins, followed by dry mouth, dry eyes, orthostatic blood pressure, passing out, fainting. Progression of the disease included peripheral neuropathy, which spread from my feet to legs up to my mid-thigh, arms and hands below the elbow, torso. Orthostatic blood pressure resulted in several bouts of loss of consciousness, sometimes resulting in injury. Neurogenic bladder caused progressive resistant UTIs that required 4 hospitalizations, resulting in required catheterization and prophylactic antibiotics. Bronchial spasms come and go, but remain constant. Weight loss due to lack of appetite, nausea, and malabsorption required hospitalization at 107 pounds and resulted in a feeding tube to restore nutrition and strength. My GI was affected with extreme constipation and diarrhea, deposits in my heart, and that's progressing. Because of the bladder and GI involvement, I've had issues of urine and fecal incontinence. Amyloid deposits in my eye caused floaters that required a vitrectomy. In terms of neuropathy, I'm currently ambulatory, but my feet are completely numb. I have no sense of temperature or pain except shocks and stabbing nerve pain. My cerebral nerves are completely dead, and placement of my feet is not exact, which often results in trips and falls. In terms of quality of life, I am divorced. I share custody with my ex-husband. I have 2 children, Josh, 13, and Sydney, 9. They're with me every other week in my condo, and they have watched me deteriorate from a full-time working mom and an athletic adventurer who was an avid skier, hiker, camper, to a mom who struggles to be able to rise every day in order to get them up and ready for school. It requires ample time in the day for medical interference in order to eat and go to the bathroom. They have witnessed days and weeks in the hospital when we weren't sure I would be leaving. And they've been strong, but there has been a toll for young children. Being brave and not admitting fears has added stress, and it has required them to mature beyond their years. Josh is the kind of kid who feels it's his job to make up for what has been lost. He parents Sydney and tries to be the man of the house when I just want his awkward adolescent years to err on the side of childhood. Sydney shows her fearlessness by helping to prepare my feedings and clean my wound around the feeding tube. She asks blunt questions in quiet, vulnerable moments. She constantly holds my hand and lends me her shoulder to lean on as we go up and down the stairs. In short, my kids are quietly fearful of losing me. They have moments of anger at the cards we've been dealt, and they have an appropriate understanding of good days, bad days, and the unknown. They secretly know that this disease has come close to taking my life and that it still might. Josh asks questions about the study drugs and placebo and voices his frustration over it not being fair. They are beautiful, amazing children who continue to pursue their endeavors with vigor and wrestle with the realities on a daily basis. Josh is a ballet dancer who trains in Denver 5 days a week, and Sydney is a gymnast who trains and competes. And I'm doing everything in my power to stay alive and see them grow into adulthood. We couldn't have made it through these many crises without my best friend, in the truest sense of the word. Lil is my guardian angel who has sacrificed time and energy and valuable moments with her own family to see that I and my family are properly tended to. She attends doctor's appointments and coordinates my care between the many specialists. As a professional social worker and therapist, and having worked in the hospice industry, she has made the sometimes very frustrating and impossible task of getting the doctors to actually speak with one another possible, and she demands attention when necessary. I am certain that if it weren't for her making my neurologist, gastroenterologist, and cardiologist see the crisis of my malnutrition and demanding that I receive a feeding tube, I would be dead. She has cleaned me up and propped me up physically and emotionally. Her smile and warmth and hand-holding is an endless supply. I consider myself lucky to have such a spirit in my corner. She has lent me her life force when mine was failing, and it is strong. But her children have come up short at times, and I fear and feel extreme guilt at requiring others' time and attention. I often hear myself explaining that this isn't me. Financially, in the past year, my copays and hospital bills for eye surgery, 3 feeding tube surgeries, 9 different meds with $40 to $80 copays, and doctor office visits are totaling at least $400 a month, and medical equipment for at-home care, including feeding tube and pump supplies, catheters, dressings, and other accessories, are totaling easily $10,000 per year on an income of less than $3,000 per month on long-term private disability. This is not sustainable. Emotionally, I've been on a roller coaster ride with the peaks and valleys of my health. This is still a terminal illness, and I've been steadfast and determined to survive at a time when the drugs and procedures are so close to being available, but not readily so. It feels as though I'm walking through a maze, and every time I think I see the exit, there's a wall that requires me to turn around and make life-changing decisions. It has taken its toll. Only recently, I have decided to take part in the Apollo study. I was reluctant to do so when I was first diagnosed because I didn't want to take the chance that I'd get on placebo, and I know that is the case for many, many patients. And I'd lose ground instead of gain it. I chose to try diflunisal and to get on the liver transplant list. As my neuropathies progressed and I climbed back from near starvation, I decided to try patisiran. After 4 infusions and an incident that I will not detail, I'm convinced that I am on placebo, and my spirits are at an all-time low. I believe in the RNAi drugs, and I want the opportunity to have had them before agreeing to a liver transplant that has never been used in a patient with my variant. I'm terrified of doing nothing and of having the transplant. Doors seem to be closing, and I'm not sure what to do next. The mess of autonomic neuropathy includes incontinence of all varieties and leaking around my feeding tube. I soil clothing in public often, and my children have had to witness such incidents. Embarrassment for me and for the kids is part of this disease. There is no replacement. There's no replacement pill one can take for dignity. Of course, if the pharma companies think that that's possible, I'm sure we'll all race to be first in line. I have lost my identity as an honored and award-winning professor and director of theater. I'm used to working days and nights in collaboration with incredible artists and surrounding my family with art and song and dance. I'm a master teacher who is used to traveling around the country to teach workshops to students and teachers who are pursuing professional development opportunities. Last year, I had to take private disability in order to get on top of an ailment that was misdiagnosed. Then the new diagnosis would come a few months later, almost exactly a year ago. It became clear that the best we can hope for is to freeze the damage where it is, and every day that I can't have the real drug or the less desirable liver transplant is a day of ability I cannot regain. I don't want to be identified by this disease. I need to maintain my creativity and guard my dignity and feed my soul. Not doing my work is killing me. Thank you.
Please have a seat. We're going to move on to David Bednarczyk from Pennsylvania. Then I'll have a question for each of the 3 of you, and we'll hear something about the quality of life analysis that's been done in this disease.
Hello. I'd like to start first by just saying again that my name's Dave Bednarczyk, and my wife and my main support person is here with me today of almost 46 years and has been at my side through this entire ordeal, this journey of amyloidosis. And I'd like to go on to back to 1988. And I'm probably more fortunate than most people with this disease because in 1988, my cousin, who was the same age as my dad, a career guy in the military, was having these symptoms, neuropathy, edema, and various other plethora of symptoms. And so after many tests, he wound up at the Mayo Clinic and got this diagnosis that he had this hereditary amyloidosis. So he came home and he alerted our family because he said there may be others. And so from that point on, I was probably around in my late 30s, close to 40 something, and we wondered and wondered for years what's in store for us, because I did see the decline in my cousin. And so I go back to the point where the symptoms manifested in my life, and it was right around my late 40s, early 50s. And I was experiencing what I thought was just old age. I have a pretty tough yard to cut. My hills, my yard is slopey and all that, and I kept losing my breath, wondering if this is just age, and with the thought of amyloidosis in the back of my mind. And so finally, I talked to my PCP about it, and of course he was familiar with my dad's case, and he knew that we had this in our family, and he ordered an ultrasound for my heart, and he says, "This is amyloid heart." And I'm like, "Oh, I don't think so, And so he gave me a pretty stiff heads up on that. He says, if you don't do something about this, he says, you might have 5 years to live. I'm like, I'm in total denial at this point. Like, you got to be kidding me. So I took his advice and took it and kept that to myself. I didn't tell my wife or share it with anybody for probably a couple more years. But in the meantime, I felt this steady decline in my physical being, losing strength, getting weaker, and just dealing with it. And then at that point, I decided I better make a move, and that's when I decided to get in touch with Boston and find out what I had to do. So I had to send my biopsy samples, and there I was diagnosed with the familial amyloidosis, and it was the LEU 33. So I came away with the only therapy was offered was that I need to go home to my hometown of Pittsburgh area and get a liver transplant, try to stop things in its tracks. And once again, I was in denial, I procrastinated, and at the same time, I thought maybe I could get into one of the trials, which I didn't. I was denied because I didn't have the neuropathy going on. So I did return the following year. I went through the same battery of tests, and no signs of progression, but I was to report back in another year, which was in around the fall of 5. And that's when I spoke one-on-one with Dr. Burke, and he put it to me pretty straight. And he said, "How you feeling?" And I said, "Well, truthfully, the last 7 or 8 months has been pretty tough. I've been sick and in and out of the hospital, dealing with bronchitis and just all kind of things. Never been sick in my life, and withering away." And he pretty much told me that this is your window of opportunity, and if you don't take it, it's going to close very soon. And so at that point, of course, after doing a lot of praying about it, it's a little tough decision, but he told me that I needed to go get evaluated for a heart and a liver transplant. So 2 days later, I made my decision to go forward, and at that point, I was evaluated in Pittsburgh and got on a list for a heart and a liver transplant. So I'll come back to that, but what I'd like to do is just give you some of my symptoms were basically conducive to congestive heart failure. I had shortness of breath, fatigue, weakness. My heart was doing crazy things. It was beating kind of off, and everything I did was just a struggle, and it was continually getting worse. So it was like to the point where I needed to, get this get this situation under control. So I realized that if I didn't, that I may not live long enough to see my children grow and grandchildren that would ultimately come along. And so I went ahead and I got on that list. I was on a list for transplant a total of 59 days. And I spent 3 weeks in the hospital. And I came home. And again, with all that, it was very difficult, with all the uncertainties and not knowing, what was going to happen, being the provider of my family, what financial costs, was going to be at the end of the road here. But by the grace of God and for the medical community and the advice of Boston and all those involved, I made it through all that. And yeah, I'm a success story when it comes down to, I beat the amyloidosis, but the scars will be there forever. And these folks that I heard this morning and some of these this afternoon ring very, very fresh with me in my mind and what they're going through. I dealt with all the same uncertainties, and I still deal with some of the uncertainties. And myself, personally, I'm more of a positive-minded person, and I always felt that, I never asked why me, why did I end up with this disease? I mean, I watched my father go through it, and we've lost other family members. I lost my older brother 2 years after my transplants, and we were all, going down that road. And for us, it's like in your early 60s to mid 60s is the end of the line for you. So I'm happy that to say that in a couple of weeks I'll celebrate my 65th birthday. And I was given 4 or 5 years to live back in 2004. And like I say, but for the grace of God, I wouldn't be here. And that's my story. Thank you.
David, have a seat. Yeah. Thank you, David, and happy birthday. So the agenda's been modified a little bit. We're going to do keypad questions and then hear from a cardiologist as well as a researcher on quality of life, and then we'll have a moderated discussion that may be a little shorter than initially intended. But we have patients here from California, Colorado, and Pennsylvania, all of whom have hereditary amyloidosis. David's told us that his mutation is LU33. Dawn and Amy, could you let us know what your mutations are specifically?
Phe64, sir.
Mine is TTR CIS114, and it's a lovely subset of the 120. It's 10 that involves the brain and the eyes, oculomeningeal. So it's a tough road ahead of me, but I'm willing to face all the challenges.
Thank you. Thank you. So if all the TTR patients would please pick up their keypads, we're going to run through this very quickly, and then we'll hear from Dr. Ruberg. Which of the following organs are affected by your ATTR? Please check all that apply. Nerves, heart, nerves, and heart, just as the patients described. Next question. Check all of the below symptoms which have had a significant negative impact on your daily life. Lack of mobility, physical limitations, fatigue. We've heard from 3 patients, profound neuropathic symptoms and profound cardiac symptoms. We're very fortunate to have Dr. Rick Ruberg from BU here today to talk with us as a physician about the challenges of dealing with ATTR amyloid. Rick?
There's one additional question there.
Go back.
Back.
Thank you. Thank you. Have you undergone any of the following treatments? Check all that apply. (22% liver transplant, 35% clinical trial for amyloidosis targeted therapy. So we have a clinical trial-oriented group here, which is great. I'm hoping to move on to Dr. Ruberg's slides here. Here we go. Rick? This is forward, and that's the pointer. Okay, great. Thank you.
Thank you very much, Ray. And I'd like to say what a privilege it is for me to be here and participate in this critically important forum, and also to hear the very moving stories of our patients as I listened all morning and this afternoon. It's very meaningful to me as a clinician. Over the next 5 minutes, I'd like to share my perspective as a cardiologist, a clinician taking care of patients with ATTR cardiac amyloidosis. And to begin, I'd like to introduce to you the concept of the patient journey. We've heard this, I think, already once this morning, but the patient journey basically can be thought of in a couple of different ways. One way is that we think of the journey that patients take from the onset of symptoms to diagnosis and treatment. But furthermore, it is our responsibility as the physicians to steward our patients through that journey and to minimize suffering and to maximize components of their experience, including longevity, of course, days required in the hospital, their well-being and symptoms, and we've heard a lot about this already, and of course our responsibility is to increase treatment to achieve these ends. And any of these are reasonable ways to look at the quality of life in which we can impact for our patients. Let's talk about wild-type TTR cardiac amyloidosis. This is the non-genetic form. And as Dr. Gertz mentioned this morning, it's probably more common than is presently appreciated because we are now beginning to look for it in ways that we didn't before. We know that TTR accumulation occurs as people get older, and autopsy series have demonstrated that TTR can be seen in approximately 25% of patients over the age of 80 to 85 years. We know that TTR increases with age, and as people are living longer, we're more likely to see more patients. And finally, we know that TTR, or we believe that TTR is probably an under-recognized cause of heart failure. We call it heart failure with preserved ejection fraction, or HFpEF. It's a way in which we cardiologists classify heart failure. And this series here from the Mayo Clinic demonstrates that when you look at patients who have died who did not have HFpEF versus those who had HFpEF, the prevalence of TTR seen at autopsy in their hearts is significant. And it's also significantly associated with gender. The blue bar is greater than the red bars here. Now, not all of these patients had clinical cardiac amyloidosis, but the general concept is that it's an age-related phenomenon that is increasing and has a significant gender bias. Now, it was previously felt that the survival of ATTR cardiac amyloidosis in wild type was not different than the actuarial predicted survival because patients were diagnosed relatively late in life. Now, of course, as we get better at diagnosing patients, we're diagnosing them sooner. And more contemporary studies, including a multi-center study that we reported, the UK experience, and most recently, our experience at Boston University of 120 wild-type TTR patients, demonstrates that the median survival is approximately 3 years, which is a significant difference than I think we previously had appreciated. What about variant TTR cardiac amyloidosis? Now, this is the case in which the TTR is mutated. The answer here probably is that it varies depending upon the population in which you look. Now, you have 3 patients here with mutations that I actually don't have cited up here because they have relatively uncommon mutations in the national sort of picture of mutations. But here you see SSA, but here I'd like to call attention to V122I. Now, V122I is a mutation that's almost exclusively seen among African Americans, and it's been reproducibly shown to occur in about 3 to 4% of African Americans. Now, that is a lot of people. The US population of African Americans is 41 million. 4% of them represents 1 million people walking around with this genotype. Now, clearly, we're not seeing that burden of amyloidosis. It doesn't exist. So the penetrance, in other words, the clinical phenotype in the setting of the genotype, is clearly low. But even so, it likely represents a significant cause of heart failure in the elderly African American population that's presently underappreciated. And this is subject of further investigation. Now, unfortunately, the presence of the V122I genotype also confers a relatively limited survival of only 2 to 2.5 years in this multicenter study compared to the T60A mutation from the UK experience, which is slightly better. Now, I want to emphasize, though, that these survival studies are all determined by the time of diagnosis. In our experience in the wild-type population, people were diagnosed at approximately 73 years of age, but didn't come to our center until about 75 years of age, indicating a 1.5 to 2 year lag from diagnosis to referral. And that's precious time in which patients could be treated and potentially have their symptoms and disease course altered. As you've heard, and very eloquently, our patients suffer significantly with ATTR cardiac amyloidosis. They experience significant signs of heart failure. They experience dyspnea, shortness of breath, edema, hypotension, limiting problems. Those who have mutations that cause neuropathy have significant autonomic dysfunction. They lose consciousness. They need medications to support their blood pressure, and they have intractable diarrhea and gastrointestinal problems from the amyloidosis. They experience frequent hospitalizations. They require frequent procedures. They require pacemakers, cardioversions, and other procedures to maintain their heart rhythm, and their quality of life is clearly limited, as you have heard. Liver transplantation, as you've heard also, while treatment for familial amyloidosis, polyneuropathy is not a very good treatment for cardiac amyloidosis. And this is because in the setting of cardiac involvement, liver transplantation often results in progression of the amyloid cardiomyopathy. And you have heard a case of a patient who is very fortunately had a heart-liver transplantation, but owing to the scarcity of organs, this is not a solution for the vast majority of patients. And heart transplantation, likewise, is also not a solution because most of the patients, unfortunately, when they come to us, are at advanced age, at which time cardiac transplantation cannot occur. So there's a great need for medical treatments for ATTR. So to summarize, I'd like to, in my mind, summarize the 3 unmet clinical needs in cardiac ATTR amyloidosis. First, we need a better understanding of the natural history of this disease so we can make more informed decisions about the efficacy of treatments. So we can have better survival studies that potentially aren't biased by referral, if possible. And we can define the comorbidities that demonstrate and influence the expression of the phenotype in the setting of the genotype. Second, we need to increase recognition to permit early detection. We believe that medical treatments will likely be more effective if they're started early and can blunt the arc of disease progression. And to do so, we need to increase public awareness in forums such as this, and improve medical education and debunk classical teaching that this is a fatal disease with no treatment options. And finally, we need to continue our efforts in biomarker discovery, specifically for ATTR. You heard at length about AL this morning. ATTR is clearly lagging behind, and in that way, we need to simplify the diagnostic algorithm and improve access to care for our patients as we work together to defeat this disease. Thank you very much.
Have a seat. There's another chair there, and there should be space. Thank you, Rick. We're fortunate to have Dr. William Lenderking here, who for the next 12 minutes will be telling us about the burden of illness, and then we'll have time for questions and a moderated discussion. This goes forward. That's the, okay. There you go. You're up. Oh, wait a minute. There you go.
They asked me to be short, but that's not easy for a guy like me. So, as a psychologist, I spend my career turning numbers or turning feelings into numbers. But I think my experience today has really been a very profound illustration of actually seeing the face of a disease and really putting life into the numbers I'm going to present to you. So I'm very grateful for this opportunity. Thank you. I'm going to be talking about disease progression and burden of illness in this condition with reference to 2 studies. They were both sponsored by Pfizer, and I am an employee of Evidera, which is a consulting company that's doing this work on behalf of Pfizer and on behalf of patients. So I don't need to say much about the background here. I'm just going to refer to that. Obviously, you all know it's a rare form of amyloidosis that can arise either by virtue of a mutation in the TTR gene or one of many mutations, clearly, or due to aging, which is known as wild type. I think we know the most about the Val30Met mutation, but there are obviously many other mutations as well. And the burden of this disease, people have obviously described it very eloquently today, but in terms of research, I think the research is really at its early stages in terms of characterizing and describing this. So, disease progression, we're going to be talking first about the Taos Study, which is a registry study, an observational study, which means no intervention, just natural history following people over time. And it's taken place since 2007 with over 2,500 patients in 17 countries at 55 different sites worldwide. It includes both patients with symptoms and a variety of mutations as well as asymptomatic carriers of the disease. The analyses presented here today will utilize the cross-sectional data, so I don't have longitudinal data to present based on a data cut that was taken in January of this year. And I will be talking about the symptomatic patients. We're also excluding patients from this analysis, those who received disease-modifying therapy, including liver transplant and the medications diflusanol and tafamidis. And in our analysis, we classified the patients according to their genotype. So we have a wild-type group, we have Val30Met, and non-Val30Met. The three different groups are different in terms of their age at enrollment, in terms of the proportion who are women, and in terms of the disease duration since at the time of enrollment into the study. The first thing I'd like to talk about is the walking ability, and what this slide shows you, it's being measures walking ability with a modified polyneuropathy disability scale. And what this indicates is the percent who are able to walk with no symptoms in the feet as a function of which group they're in. So the wild type folks are on the left, non-V30Met in the middle, and the V30Met on the right. So as you would expect, probably the people with the more cardiac involvement in the wild type have better preserved ability to walk in general. There's some decline due to probably cardiac reasons, whereas those in the V30Met, which is very much affecting neuropathy and peripheral symptoms, are showing a real decline. And the colored bars indicate the duration of time since symptoms began. So as you can see, moving from left to right within each group, the ability to walk and the prevalence of symptoms, the ability to walk declines and the prevalence of symptoms increases. This is using a very commonly used index scale that measures quality of life on a scale from 0 to 1. It combines, it's called the EQ5D, the Euroqual, and it combines 5 different attributes, including mobility, pain, there's an anxiety and depression component as well, into a single number, again, representing from 0 to 1, and it shows you how this condition compares to other common conditions. For example, very common, the TTR variants are listed in the red bars, and it's very similar to diabetes and sort of in between diabetes and stroke and rheumatoid arthritis. So wherever possible, we used pre-existing measures that have been validated so we can make this kind of comparison with norms. This is some survival data, which is also, I think, quite comparable to some of what you've seen earlier today. So you can see that this Kaplan-Meier curve is a special variation on Kaplan-Meier where we used a delayed entry approach, and those with the V30M genotype are showing a better survival. That's the blue line over time. And those with the wild type are showing a median survival a sort of 50% death rate by 3 years. So that's the black line there. And so the non-V30Ms are in the middle. Okay, now I'm going to switch gears to the other project, which is a much smaller project. It's an internet-based study, online survey administered in the US, again to patients with TTR, but we also include caregiver data. We have several different outcomes that we looked at: physical and mental health, work productivity, health-related quality of life, and healthcare utilization. This was actually an anonymous survey, and all the procedures were reviewed by IRB and approved. And caregivers were also asked about the burden associated with providing care. Here's the demographics of the patients. We have 44 patients. There are 6 with cardiomyopathy. The rest have the other variation, and 24 caregivers. Predominantly male, not even half the group employed at this point. 45% reported being unemployed due to ATTR. 39%, that's a little bit higher than what was polled in the audience, had a liver transplant. 86% with a family history of ATTR, and 32% indicating they required at least some assistance to walk. Okay. This is another a very well-known health status scale, the SF-12, like the SF-36, which you heard about this morning. And the basic take-home here is that the norm in the US population is a score of 50. So getting a score of 30 means you're practically 2 standard deviations below the norm. And what does it's a very abstract concept, 2 standard deviations, but in fact it means you're considerably impaired. And the patients in this particular sample reporting a great deal of physical impairment. However, their well-being, their sense of the mental component summary was actually fairly close to the norm population, which was a surprise and not necessarily consistent with what we've heard today. However, the caregivers showed the opposite pattern. So the caregivers, some of whom actually did have the disease, showed a little bit of a decline in physical functioning. So they're in the beige bars there. But their mental summary was actually lower than the patients. So perhaps they're sort of carrying the anxiety and depression and burden that some of the patients, for the patients and worry. So here is some data on a limited percentage of the people who are actually working or trying to work based on the work productivity and impairment scale. Of those who are actually working, they were on average missing 1 day a week. 22% of work time was missed. Impairment while working is the next variable here. Impairment while working, 40% reported feeling that they weren't fully productive at work. Overall work impairment, 47%. And in terms of overall activity impairment, nearly half the sample, of course, is reporting this. And that, the beige bars, again, are the caregivers, so you can see comparable levels there. In terms of healthcare resource utilization, there's a significant impact of this disease, as you heard. Compared to the general population, 80% of people reporting at least 1 outpatient visit, and we heard, I think somebody said 122 visits to doctors in the last year, so this is not inconsistent with that. We had a large proportion, 1/5 of the patients going to the emergency room within the past 3 months. 16% of patients and 20% of caregivers were hospitalized at least once. The out-of-pocket cost for travel ranged from $0 to $4,000 a month. Now, the average was $45, but this is just travel costs, right? Half of the patients reported they were unable to complete household chores, with almost 1/3 indicating they had to have they had to pay for assistance to complete them. The caregivers face additional burdens, which I don't think we've heard quite as much about the caregivers today. The majority were the primary caregiver spending as much as 47 hours a week, more than a full-time job, taking care of the patient. On average, they had been providing care for a little over 3 years and rated their fatigue level as a 6 out of 10. They reported symptoms consistent with mild depression and anxiety. And surprisingly to us, and we've checked this data over and over again, about half the caregiving sample also reported that they were dealing with the disease as well. So perhaps they were carriers, they were children of the patients. And they reported paying a median of $1,200 out of pocket for patient care only in the past 3 months. And we also administered, I didn't present the data on this, but we administered a burden of illness questionnaire. And the burden of caregiving for these patients is comparable, based on the scores, to caregiving for Alzheimer's patients. So in conclusion, remember I presented 2 studies here. The first one, the Taos Registry. The primary conclusions are that this disease progression can result in a high degree of walking impairment, especially those for mutations associated with neuropathy. Life expectancy is shortened, especially for those with mutations recognized as having more of a cardiac impact. In terms of our burden of illness study, the significant degree of disease burden can make it obviously very difficult for patients to work and engage in day-to-day activities. Greater impact was seen on physical than mental well-being in our sample. ATTR results in a significant degree of healthcare resource use. Health-related quality of life is comparable to other more serious conditions. So for example, we presented data on diabetes and stroke and so forth. And the caregivers also experience reduced mental well-being characterized by depression and anxiety. Many may also suffer from ATTR themselves, and the amount of time that they spent caregiving translates to more than a full-time job. So thank you very much for your attention.
Yeah. So as many of you may have noticed, we're behind schedule-wise, which is why I cut my hair short so Isabel would have a difficult time taking my scalp. But I do want to thank the patients and the doctors, and I'd like to ask Dr. Farkas what the session has told him thus far.
Is this on? I guess it's on. So first I'd like to say these are opportunities that I certainly really look forward to come and hear about the diseases that patients have, and to get a better understanding of their symptoms, and to take that information back with me to talk to the drug companies, and I think often to tell them that the FDA is more open to measuring drug effects on more kinds of symptoms than they might have thought. And so one thing that I just want to reassure everybody about is that the FDA is an organization that takes pride in being careful, but I think it's also an organization that takes pride in being reasonable. And anytime there's more than 2 people in the room, there's a disagreement about perhaps what reasonable means. But again, and I think one opportunity coming out here to talk to patients is that we're constantly thinking about what reasonable is. And I think that's one of the most important things, one of the most important kind of messages, that we are a detail-oriented organization. We take pride in the good science that we do. But we get our understanding of reasonableness from patients and providers and caregivers. So we are listening to you, even though we sometimes talk in terms of p-values and distributions and drug substance specifications and those kinds of things. And so I'll just say one other thing too, or kind of across the gamut of some of the things that we've heard today. So the size of improvement that we're looking for is something better than would be provided by a placebo, something better than nothing at all. And there's a certain amount of evidence we need to support that. this idea of substantial evidence. But that's what we're looking at, trying to identify if there's a drug that beats nothing at all. There isn't any kind of expectation of a miracle or a large effect or anything like that. I see we're behind on time, so I'll finish up real quickly. The one other point, too, is that from this morning, there was a lot of discussion about biomarkers, and we do pay attention to that also, and we want to be careful, but we're looking at all the data that comes to us to see how that could support if a drug is working or not. Thanks.
Thank you, Dr. Farkas. So I think we have time for 2 patients, and I want to ask if the patient would mind, patient with TTR, hereditary amyloid, would mind just answering a few questions. Sure. So you've seen the list of symptoms. Which one symptom has had the most significant negative impact on your life?
The symptoms that has the most right now is the edema, because it does make it difficult for me to walk. But there's ways to treat it so that I just work on treating it.
So you have transthyretin amyloid?
Correct.
Okay. And what specific things does the edema prevent you from doing?
Climbing stairs.
Climbing stairs. So how do you deal with that?
Either I send my husband and say, trust me, at first he lost a lot of weight. And hated the phrase, honey.
I need you to.
Would you mind? But more than likely, I would go very, very slowly. It would take me a half hour to go up 7 steps, and then I would have to wait.
Did you ever sit from step to step going upstairs?
No, I couldn't sit.
Couldn't sit.
I couldn't get down that far on my knees. I would basically just slowly work my way with grabbing onto the banister and pulling, begging, wishing, and yelling at him for not having an elevator in the house.
Thank you.
Less steps than your townhouse.
Yeah.
Thank you, thank you, thank you. One more patient with TTR amyloid. Willing to answer a few questions. Right back there. So what one symptom has had the greatest negative impact on your daily life?
Actually, I have 2. Right. I have neuropathy in my feet, and it's impacted my driving. The other day when I was driving, my shoe came off my foot and I didn't feel it, which can be very dangerous when you're going from the gas to the brake and back again. The other one is floaters in my eye. I've had 2 eye surgeries, one for glaucoma and one to a vitrectomy because I was almost blinded in my right eye. But because of the neuropathy and the vision, I only drive in places that I'm sure of, which is very little driving at all anymore.
Sure, you have to drive in the daytime?
I can only drive in the daytime, and he doesn't like driving at night either. Yeah. So since we live in New York and it's dark by 4:30, we're in by 4:30, which is quite an impact for somebody that went out all the time and drove, got into the car and went wherever I wanted for 2 minutes or 5 minutes or 10 minutes. Now I don't.
Thank you. Thank you. The ocular floaters we haven't talked about, but they are characteristic of hereditary amyloid. Okay, without further ado, I'd like to thank everyone. I'm going to pass this along to Dr. Gertz. On schedule.
Thank you. As we move on to the final sessions regarding approaches to treatment and clinical trials, we'll invite back Professor Merlini from Pavia to give us a 10-minute summary.
understood more. I will not use more time than this. Well, in 10 minutes it's impossible to go into details, but I would like to just give some messages to the patient mostly. So in this disease, we have made great advances that comes from basically two factors. The first one, basic research. And we are fortunate to have in the audience here one researcher from Academy, Jeff Kelly, who contributes greatly to understand better the disease, but also researchers from companies. And we have some brilliant researchers here. Don't mention them because I will forgot some of them. But indeed, there's been a common effort. And I was particularly touched by the presentation before. And if I have to answer a Ray question about what is important, I think that is time. Indeed, time is a key factor for you. And we cannot wait years to get the outcome of trials. We have to be, of course, reasonable, but we have just to move faster. So, having understood all this, it might look complex, but some key steps that we understood here were critical to develop new treatments. And the search goes on. So we know now that is produced by 95% by the liver. We know that this mutation favors the dissociation to the monomer. And having understood this critical point has opened the windows for new treatment. We know that this monomer then misfold, and we know now that proteolysis and shear forces, what is called mechanoproteolytic mechanism, is going also to play a role. And again, this will open new therapeutic opportunities in the future. We know that there is this specific targeting to organs, and this is another important point in research. We don't understand now the basis of this specificity, but understanding this, again, will be of primary importance. So we have mutations that just affect specifically the heart, and some are prevalent for the nerves, and autonomic nerves, as we have listened this morning, can be devastating. And some other, as we have learned this afternoon, also the CNS, the leptomeningeal variants. And some of them are mixed. So we know that oxidative stress and inflammation also play an important role, all in this cascade. So from this we took some therapeutic opportunities. So as it was said eloquently recently in a meeting in Paris, so far we are changing the liver to substitute one amino acid. And this does not make a lot of sense, of course. And rightly, the companies developed these new technologies of gene silencing, and both using small finger RNA, alnylam on the antisense oligonucleotide, this is ISIS. And these are in clinical trials now. And the preliminary data are extremely encouraging. The understanding that this tetramer needs to dissociate led to Jeff Kelly and other investigators to develop specific drug that can cement this tetramer. So you just stabilize it. So hopefully this will stop the whole cascade of events. So in theory, this is a substitute of liver transplantation. And both the tafamidis has underwent extensive experience. Now we know the long-term results are very encouraging. It's a very safe drug. And it can stabilize in almost 70% of the patient the disease in 5 years of treatment. John Burke here was instrumental to test diflunisal and to prove that it was possible to reach the primary endpoint in this, thus stabilizing the neuropathy in this patient. The data on cardiac effect are still more less certain, at least. You will speak about what is still open. And we can also drive off pathway disaggregate using epigallocatechin gallate, this green tea extract. And there are some encouraging data on cardiac involvement from Germany with this compound. So it has been always considered to be kind of just a diet adjunct, but it's really, I mean, also basic science is good here. So there are pretty good evidence. And of course, targeting the amyloid fibers, as we have learned this morning. We have GSK that is heavily involved in this approach, thanks to the discovery of Sir Mark Pepys in London. And also the Proteina group is also working hard to develop a remedy also for TTR amyloid, not only AL. So, and recently we have evidence that oxidative stress is also important. So in Pavia, we are starting now a trial using anti-cytokines drug. Low, they are not too expensive, and we expect to have benefit also in patients, thanks to the study by Maria Saraiva in this field. So coming back to the patient that spoke this morning, there is hope for this disease. And we all recognize that there is also, the time is a factor here. So with FDA, the companies, and as a community, we are very much committed to speed up the whole process. Of course, we have to keep in mind the efficacy and safety of the drug, and we all do this, but there is hope for this patient and for this disease for the first time. Liver transplant is extremely effective. We know now which are the patients who benefit most. They are young patients with the MET30 mutation in a rather early stage of the disease. So for this patient, there is a clear-cut indication. For the other patient, the indication is a question mark because the long-term benefits are not so strong as in these cases. And we have seen progression of ocular, cardiac, and polyneuropathy after liver transplant. And for this reason, liver transplant procedures worldwide, according to the Worldwide FAP Registry, as you can see, has dropped significantly 8 times during the last year because of the availability of these new drugs. So at present time, using what is available in Europe and in the States, you don't have tafamidis yet, unfortunately. So in Europe, for stage 1, tafamidis is our first choice. Liver transplantation in that selected patient population is an indication. And of course, we encourage all of our patients to participate into trials, both with patisiran and ISIS. So these are early stage patients. In patients who can still walk with the aid of 1 kN maximum, diflunisal, it looks like as a good indication. So John Burke may comment on this, but I believe it is a good indication. Again, we encourage all our patients into trials. For stage 2 and 3 patients more advanced who need 2 stretches to walk or are on a wheelchair, diflunisal may be used and supportive therapy. With patients, as we have heard recently, with heart involvement, liver and heart transplantation is a good indication, but clearly depends on organ availability. That is a real problem, particularly in Europe, more than in the States, I must say. Phase 3 trials with revusiran is also possible. In Pavia, we have developed this simple treatment with doxycycline and TUDCA, and we just presented good results, particularly in patients with heart involvement. And diflunisal is also an option for these patients, but we do believe that doxycycline might be better. All this leads us to the point that we need trials and we need consensus. So we need guidelines now to help our patient to choose what you do, and as a community, we need to get together and provide directions. I'm still in time, right? The last slide is the courtesy of Laura Obici, just to underline the importance of an integrated care of this patient. patient family, as we have heard before, is really has a great burden from this disease, but is really a joint effort of different specialists here working on this disease. And we underline the importance of the referral physician because there must be somebody who is directing this and increasing the confidence of the patient, increasing also the compliance to the treatment. So we do believe that specialized centers with referral physicians are critical to this. And of course, I cannot underline again more and more how is important early diagnosis. We know that we miss most of the function during the first 2 years when the symptoms start. We just publish it. So early diagnosis is still the main goal in this disease. But again, coming back to the patient, there is hope for this disease. As you have seen, many tools are under development. We will do our best to accelerate all this process. Thank you for your attention.
Thank you, Gianpaolo. We're going to hear from 4 patients now, and I would ask all 4 of them to come up to the podium now. Dr. Savitz, Mr. Leatherman, Ms. Beckwith, and Ms. Brink to please come now. While they're coming up here, since I'm being recorded, I'd like to share one of the frustrations that many of my patients have brought to my attention. Obviously, we want to bring agents proven to be effective to all patient populations. But we're in a situation now, because of the diflunisal data, that to participate in a phase 3 trial, we're asking patients, and I understand about not obscuring endpoints, to discontinue diflunisal in order to participate with a 1/3 chance that you'll be randomized to placebo. So it's not no therapy to no therapy, it's on diflunisal to no therapy, and I think this has been a challenge for a lot of our patients. It's a major block for enrollment. So with this, let me introduce Dr. Savitz. Please, thank you very much.
Good afternoon, ladies and gentlemen. I am Dr. Barry Savitz, 81 years of age, from New York City, and I've been practicing surgery for 55 years, and in Brooklyn since 1973, and I still practice 1 day a week. I was chairman of surgery at the St. Mary's Hospital and the King Brooks Jewish Hospital in Crown Heights in East New York neighborhoods for nearly 30 years. I've been involved in residency and medical student training and fostered outreach clinics and community services in my career. I spent a year in Cuenca, Ecuador with Project Hope in 65-66, before Doctors Without Borders, to rehabilitate and successfully salvage a failing medical school, which worked, and to train its medical staff. And I was in Afghanistan in 76 for two months, and Kenya in 2011 with a medical team. At present, I work 1 full day a week at the Bedford-Stuyvesant Family Health Center and do surgical and orthopedic case management. I would like to do more, but can't. I'm also a patient with a diagnosis of senile wild-type cardiac amyloidosis and have suffered chronic fatigue, weakness, shortness of breath, won't exercise, although I still push myself to the gym twice a week, and atrial flutter and fibrillation, which was not well controlled, tachycardia to 110, mini-stroke, nosebleeds, early hypertension, leg edema, and fibrosis of the plantar surface of my feet. A pacemaker has allowed some temporary or symptomatic relief, but I think the disease is possibly progressing. The diagnosis was made by a colleague at Methodist Hospital in Brooklyn on a hunch and diagnostic after I said that I had chronic fatigue. And I was working full-time at the time 4 years ago. And he did some studies, and of course it proved positive. I am on the tafamidis protocol, which is sponsored, or at least partially involving Pfizer, for the last 6 months. The protocol has 3 arms. On 20 milligrams of tafamidis, there are 30%, 80 milligrams, 30%, and the placebo is in 40%. And it will go on for 30 months. However, unfortunately, after the 30 months, there's still people being put on the protocol, and they won't be able to wrap up the study for a longer period of time than 30 months, but each individual will be on 30 months. I've always maximized my efforts in therapeutics in the current and using current and novel modalities. I performed at St. Mary's from 1974 to 76 in developing the surgical arm for a joint study with Dr. Harry Levine at the Brooklyn VA and developing the peritoneal jugular shunt for treatment of intractable abdominal ascites and liver and malignant diseases. Now, I want to point out that when we used it, it was untested, and it was not formally approved. We just used it with the patient's consent, of course. And we used it in untreatable patients, and it worked, and it's morphed into a more sophisticated descendants, and is still employed. Tafamidis, as those who spoke with me briefly, works perhaps not on all patients, but it seems to be on most. It is the most promising medication currently in use for managing TTR disease, amyloid disease, and it is the only hope for prolonging and salvaging patients. I predict that with the newer modalities for diagnosing this syndrome, a heightened awareness on the part of cardiologists and increased access to health insurance, there'll be a surge in TTR clinical recognition. Therefore, there is a need for here and now therapeutics. So my question is this: is it right or even morally correct to glacially running trials of this drug involving a sick but potentially salvageable population with a placebo arm of 40% or the extended length of the study on tafamidis, which will be 30 months plus? Why not just accept earlier studies and clinical experience as valid data establishing tafamidis' safety and success, and it's approvable? And approved by multiple other nations, including our allies, as an excellent reason for early approval of tafamidis for use in the amyloid disease. What I've heard today, however, has regarding your stoicism and the grit, tough grit of my fellow, shall I call them amyloidites? I promise never to complain again.
Thank you, Dr. Mr. Leatherman? Thank you. Thank you very much. Mr. Gary Leatherman.
Good afternoon. First of all, my wife is watching from home, so I'd like to say hi. 7.5 years ago, I was diagnosed with TTR FAP, a disease that has affected 7 generations of my father's family. My father died in an accident when he was 27 years old. I was 4. So I lost that link, a very important link. Although I kind of remember family members that were in wheelchairs, who had difficulty walking, who had burning limbs. I only heard the term TTR from my aunts. My aunts came to my house. One of my aunts had just been diagnosed with TTR FAP. That was the first time I heard the term. They referred me to Johns Hopkins and Dr. Judge. That was very important, and without that visit from them, I probably would not be standing here today. I had some pain in my hand that I thought came from being an IT manager. I thought I had carpal tunnel. I was wrong. My heart biopsy came back positive for amyloid. My genetic test came back. I had the disease. I was well aware of family members again and what they had gone through with this disease. Horrible pain, extreme degeneration of limbs to where they could not walk, they could not feed themselves. It was not much to look forward to. There's a family history that was done on the Eigenbrode family, which was my grandmother's family. We used to call this Eigenbrode disease because long ago it didn't have a name. So it was called Eigenbrode disease. But that quote is, the illness, familial amyloidosis, has permeated the Eigenbrode family since 1839. That's 7 generations. My treatment options at Hopkins were very limited: liver transplant or clinical trial. I looked at both. I talked to someone about having a liver transplant, and I met with Dr. Judge about a clinical trial. I chose clinical trial. I have 5 children. The only hope that I saw was to do it for them. I have a daughter now that's 38 years old. I know when I first started having symptoms, my goal in all of this is to have something that they'll be able to use. I don't want them to go through what many of you have gone through. I wanted to get this done before they plan to have a family. I have a grandson now. And of course, he's adorable. But you look at your children and you think of them first. When I met with them to let them know about this, it was a horrible day for me and my wife. You know, to let our children know that I may have passed something down to them that there's no cure for and really no treatment for. Now some good news. I have been taking 20 milligrams of tafamidis every morning for the last 7 years. I have not experienced any side effects. I see a cardiologist every 6 months. My tests are all good. My echoes are good. By using tafamidis, I am really fairly well. I'm doing good. My quality of life is very good. At age 63, I work 10-hour days as a patient transporter at a hospital. Without tafamidis, I don't think I'd be able to walk the 10 miles or so a day that I do transporting patients to tests and doing admissions and that type of work. And when I get tired by the end of the day, I know it's because I'm 63, not because of this disease. From a patient perspective, I would like to see tafamidis available to everyone. I've heard a lot of stories the last couple of days here. There's some very sick people. I am very lucky. When I was first diagnosed, the only options that I had was liver transplant or clinical trial. 7 years later, they are still the only options. Something needs to move forward. From my experience, tafamidis is a good drug. I think it saved me from going through what many of you have had to go through. Thank you very much. And my family thanks you very much also for the opportunity.
Thank you, Mr. Leatherman. Now I'd like to introduce Cecilia Beckwith.
Good afternoon, and I'd like to thank the FDA for taking the time to listen to us today, and the Amyloid Research Center for inviting me to speak. I have transthyretin cardiac amyloidosis caused by V122I, which is one of those, and it predominantly targets the heart. I have a very, very, very mild peripheral neuropathy, and it's really not that rare. Many research studies estimate the genetic positivity or genetic prevalence to be about 3 to 4% in the Black population in this country. And I was just listening. It's hard for me to believe that approximately 1.5 million African Americans carry the V122I gene. And in spite of its high prevalence, the most frequent way that it's diagnosed still is on autopsy. And this is just unacceptable. I'm alive today because I'm a nurse practitioner. I know that. With the knowledge to recognize the diagnosis given to me really didn't fit what was going on inside of my body. So no fatty liver, no asthma. I have incredible support from my family and friends, and I truly had the financial resources that allowed me to be persistent and find the right answer. It was a very expensive endeavor. In order for me to achieve a definitive diagnosis, I ended up at Boston University. I had to travel 3,000 miles to a specialty center. I was living in Seattle, Washington, and there was no one that was really familiar with transthyretin cardiac amyloidosis there. A hematologist, actually who'd been trained in Boston, got me to Boston. Currently, the definitive treatment for my disease is a heart transplant. And until recently, there were really no clinical trials for transthyretin cardiac amyloidosis. And traditional therapy for heart failure, in fact, may cause many of the symptoms to get worse, and they need to be used in extreme caution. I did receive a heart transplant 3 years ago, and I'm appreciative that my life has been lengthened and extended, but it comes at a heavy cost. I had to relocate for 9 months to Northern California in order to be transplanted and to receive my care. I'm no longer able to work in a profession that I love. I'm no longer able to work as a nurse practitioner because I'm immunosuppressed and, in fact, at risk for infection. I actually live with the constant fear of rejection. Even though I've never had rejection, it's that mental health piece. You just are constantly afraid. And my children are also positive for V122I. It's hard, it's really had an impact on our family, and my 29-year-old daughter and her son and my son-in-law are really not willing at this point to consider having children because of watching what I've gone through. You know, a heart transplant is truly not the definitive answer to managing transthyretin cardiac amyloidosis. I think we're in a crisis. And the general consensus that the mutation I have, V122I, is misdiagnosed, underdiagnosed, and it results in incredible morbidity and mortality. I believe that there's a profound urgency to change the situation. I agree that there needs to be a concerted effort to educate the medical community about transthyretin cardiac amyloidosis and its symptomatology. Clinical trials are the only means we have to develop effective new therapies. And there are some promising new therapies. African American participation in clinical trials is critical. We continue to be underrepresented in clinical trials, and this is rooted in a well-founded fear based on historical mistreatment. As a healthcare provider, I understand the essentials of clinical trials and the human subject protections that now exist. But to the average person just navigating the healthcare system alone is overwhelming. I believe that a joint effort from the medical community, governmental agencies such as the FDA, pharmaceutical companies, and members of the African American community must form an alliance to implement major cultural changes in how clinical trials are conducted and presented to my community. I personally am committed to raising awareness. Without effective action on all of our parts, members of my community will continue to prematurely die from transthyretin cardiac amyloidosis. We can bring that to an end.
Concluding, Ms. Jennifer Brink.
Good afternoon. My name is Jennifer Brink. Just to tell you my story, so we all have our stories. I am a professor of respiratory care. I am a registered respiratory therapist and have been for 31 years. That has played an impact on my amyloidosis as well. So to understand that for 31 years I have been at the bedside, life and death. For 31 years, I have been behind the patient. I have been the one procuring for transplants. I understand I'm the one who pulls the plug. I get life and death. So just to understand that I am intimately involved with not only living this, but also taking care of the patients with this as well. I've been married for 30 years to my husband, Daniel. I have 2 daughters, Paige, who is going to be 26 years old. Paige is a graduate of the United States Military Academy at West Point. I have another daughter, Logan, who is in her senior year at Ball State University with a chemistry major. Paige is currently working on her master's degree in biomedical engineering. I bring this up because when you want to talk about family influence, my daughters have grown up with familial amyloidosis, and because of that, both of them are choosing to go into professions that may be able to someday cure their mama's disease. How pathetic is that? So just to understand where my family comes from, I am the Dubaugh. Gary, you had your family. I'm the Dubaugh disease. Just so you understand where I am at, for my medical staff that's in the office or in the room today, in 1956, Dr. Charles Eugene Jackson, known as Gene Jackson, wrote an article in 1956. It was, in fact, titled Primary Systemic Amyloidosis, a Review and an Experimental Genetic and Clinical Study of 29 cases with particular emphasis on the familial form. That is my family. We were the first diagnosed familial amyloidosis in the United States. Bluffton, Indiana. I have 6 stoplights in my town. In the 1960s, there was an amyloidosis symposium held at the Kaler-Nickel Clinic in Bluffton, Indiana in the 1960s. It was attended by physicians from Japan and Portugal. I was diagnosed, let me go forward then, and my entire family was tested between the 1983 and 1984. I was 18 years old when I first met Dr. Merrill Benson. I am very well known to Dr. Benson. He is very well known to I and my family. I have his personal phone number in my cell phone if any of you would like it. So when I, yeah. So Dr. Benson discovered our mutation. I am an Eileen 84 serine. In 2005, I underwent my first carpal tunnel release. I had a biopsy at that point to prove that I had penetrance. My grandmother, so my family history, just how I grew up in the Dubaugh family, the Carr family. My grandmother dies when I was 6 years old. This was in 1969. Fast forward to 1983. I am now a respiratory student at Butler University in Indianapolis, Indiana. I am now helping my aunt making end-of-life decisions with my Uncle Bud. So I was at bedside listening to the physicians when they were going on with his end-of-life. That was my first choice of making end-of-life decisions. I was 19 years old when I was assisting with my aunt with her end-of-life. Should we dialyze? Should we not dialyze? Do we just end here? My uncle, so he dies in 1983 at the age of 61. I have an uncle who dies in 1984. He was 54 years old. My father, Phil, died in 1995. We celebrated his 20th anniversary of being gone. He was 61 years old. He was declined a heart transplant because of his peripheral neuropathy at that time. Moving forward, I have a brother, Scott, that just passed away in 2009. My brother, Scott, was 53 years old. He passed away one day before he was to go to Cleveland Clinic to get worked up for a heart transplant. He was prepping for the colonoscopy. My opinion, he suffered an fatal arrhythmia from a electrolyte imbalance. In 2010, my cousin dies at age 63. She actually developed cancer, did not actually die of amyloid, but due to the amyloid, cardiac amyloid, her chemotherapy for her cancer treatment was significantly impacted. My brother Mark dies in 2013 at age 58. He spent 4 months waiting on a dual heart-liver transplant that never came. All of my family has died of end-stage cardiomyopathy. Dr. Benson has attended my family's funerals. It's quite humbling to see Dr. Benson drive 2.5 hours from Indianapolis to attend family funerals. We have stockpiling of equipment that goes on in my family. So when one family member dies, we just stockpile their equipment. So all you have to do is call up my cousins to find out who has the commode and who has the wheelchair and who has any other devices that the rest of us need. We just keep them in a family basement. Yeah. I watched my family go through some very non-traditional treatment because there has been no treatment. Back in the 80s, there was a very prominent Amish man that lived in the Northeast Indiana community that was very into iridology. Now, being a medical professional myself, when your family comes to you because Mr. Wiki has diagnosed you with gosh only knows what, and you take handfuls and handfuls and handfuls of herbal supplements. I have watched my family be on colchicine. I still get asked, are you on colchicine? And I'm like, are you crazy? I don't have gout. Okay, I don't have it. I've watched my family be on vitamins. In matter of fact, I just had a cousin 3 months ago called me because she has no cardiac involvement and said that she thinks the reason is because of Shackley. Now, if you're a Shackley vitamin taker, kudos to you. Again, I've not taken any Shackley vitamins. I've watched my family juice. I watched a cousin turn so yellow from carrot juice you can't even imagine. Very non-traditional. So I am 51 years old. I am soon to be 52 years old. I was diagnosed at the age of 20. I have been waiting 3 decades, 30 years to give me any medicine whatsoever that you can give me. I don't care what it is other than Shackley vitamins and sending me to Mr. Wiki and making me turn orange from carrot juice. To understand my involvement in the familial amyloidosis, Dr. Benson would call myself and my brother up and say, hey, I need some DNA, I need to grow some more mice. So for all of you physicians that have ever had a white mouse in your lab, I bet it's a Jenny mouse. It might be a Scott mouse. Dr. Benson has sent my mice all over the world, and yet I can still not get treatment for my. I was denied entrance into the clinical trial because I do not have lower extremity neuropathy. I saw Northwestern this year for the Apollo study in Chicago, and they saw me. I also saw Mayo Clinic this summer, and they saw me. I was told twice this summer as they were pushing on my feet, why, Jennifer, you don't have cardiac failure. You're in great shape. It's a great time to have amyloid. And I actually looked at the Mayo Clinic physician and said, really? Is it really a great time to have amyloid? We as clinicians really need to watch what we're saying to our patients because it's not a great time to have amyloid. I was also told that women live longer. I have one example. I have an Aunt Beulah that died at the age of 75. My Aunt Beulah was bedridden for 5 years, completely blind, orthostatic pressure, and all of the horribleness that all of the other families that have talked about. Although her quantity was much higher than the normal 53, 61, her quality was just deplorable, and that is not my choice. So by telling me that I'm going to live longer as a female does me no service either. I suffer from moderate to severe neuropathy in my upper extremities. I have moderate sleep issues. I change beds nightly just because my arms are asleep, so I'm just up pacing and changing beds, the dogs and I. I do have EKG changes showing low voltage as of 2013, and that was diagnosed by Dr. Benson. So as an unmet need, obviously my only treatment option is liver transplant, as I cannot get into a clinical trial, although that you have a family history significant that you can go back to any, if you want to read any article on amyloid, and if you ever see the Indiana Swiss kindred, you are talking about me, and you are talking about my family. I am now becoming somewhat desperate to get treatment. This past winter, spring, I testified before the Indiana Senate as a right to try law in the state of Indiana. It was passed unanimously. That right to try law took effect on July the 1st. On July the 1st, I petitioned ISIS Pharmaceutical for my right to try. I was given a very wonderful Dear John or Dear Jane letter from ISIS Pharmaceutical that I, of course, will mess up their numbers, and there's no way that I can have ISIS, I can be part of their clinical trial, even though I have known Dr. Benson since I have been 18 years old. I cannot get into his trial. So now my desperation has turned to, I am still pursuing the right to try laws. Amy from Congressman Stutzman's office, are you here today? Did Amy come? I'm working with Marlon Stutzman's office. He is a congressman from the state of Indiana. He is currently putting forward a federal right to try law. I've been asked to bring his face. Whether that right to try law will get me anything, I doubt. Right to try laws are not getting us access to drugs. I cannot get an access to any drug. But it's a great time to have amyloid. And I look really, really good because I don't have any health or any heart failure yet. It's a very hard, hard thing to hear. So at this point in my life, to the FDA, I am willing to try any trial that you will let me in. The advantages, the risk, and the advantages to that far outweigh me just continuing to progress, because that's all I continue to do. I do get well, come back in 6 months and we'll shock your feet again. Maybe you can get in 6 months. Oh, good. So when I've gotten worse, not better. I am still working full-time as a professor. I still work full-time. 90% of all the respiratory therapists in Northeast Indiana are a product of me. I've done something to change the world, maybe in my part of the world, maybe not the amyloid world, but I've changed healthcare, and I'd like to think that healthcare, that as a clinician, I'm not going to give up on the healthcare and what we can give to our patients. So if I was allowed in a trial, my risk, I'd do anything. I'd do anything just to be able to go, hey, at least I'm trying, instead of being pathetic, instead of going, oh, can I please have a right to try your drug? No, I'm sorry, you're going to mess up our numbers. Okay. Well, then what do? Wait till I am disabled. Wait till I can no longer work, because that's my option. That is the option that I've been given at this point. Just so you understand, my immediate family, I need you to understand something as I go home. The Carr family is going to be having Carr Christmas on Sunday, December 6th. My family is the host of that this year, the Phil Carr family. So I want you to give it a little genealogy, because we're a very, very close-knit family. I have over 150 relatives, and we live in 2 counties. We are very much a farm family. So when I host my family on December the 6th, my grandmother, Elma Dubaugh Carr, had 7 children. Of her 7 children, there were 4 affected. 1 was my father. Of her 7 children, they had 24 grandchildren. I am affected. I am one of those grandchildren. There are 9 of us. I have 9 cousins that are affected. Out of us 24, we have had 71 grandchildren. Out of those 71, we have only had 3 that I know have been tested. 2 are confirmed positive, 1 is confirmed negative. Out of that 71, that generation has now had 65 additional children. Right now, in my immediate Elma Dubaugh Carr family, there are 33 members of my family that I will see on Sunday, December the 6th, that have not had any access whatsoever to any trials at all. And I will go back and I will tell them that we're still waiting. We're still waiting. Thank you.
Could you bring up the afternoon questions, please? Have your keypads ready. We'll be going through a number of questions regarding your experience with TTR. Thank you. We'll start with the first question. What would you rank as most important to your decision about treatment? You get 2 choices: whether the treatment is expected to help relieve symptoms and quality of life; 2, the toxicity, the side effects, such as neuropathy or cardiac; whether the treatment could possibly prolong life by slowing progression; the expected side effects of the treatment; and how the treatment is administered, the logistics of the treatment. We had the same question for AL amyloidosis earlier today. Please vote. Timer. Thank you. This information will be recorded and compiled so you can see expected to help relieve symptoms and survival. We'll move on to the next question, please. Next question, please. We have no other questions? Okay, we're good. Thank you. Before we move on to Dr. Burke, just a couple things, my housekeeping, because we had a lot of people sacrifice to come today. We wanted to say thank you to the patients, the physicians who came of their own free will, scientists, caregivers, our pharmaceutical representatives who wanted to hear your stories, representatives from patient advocacy groups as well. We also owe a great debt to the FDA because they provided us with a platform to share these stories, and we're grateful for the time that they've spent to understand our plight. And of course, none of this happens, none of it will happen at all without Amyloidosis Research Consortium, so we thank Isabel Lusada and Mary O'Donnell for putting this all together. Professor John Burke from the Boston University Amyloidosis Center is internationally known. He was the individual who conducted the trial of diflunisal and demonstrated its ability to slow the tempo of neuropathy progression. He's made a number of seminal observations over the years. It's a pleasure having him here. Dr. Burke.
Thank you very much. Thanks for sticking around. I'll try not to put you to sleep. See if we can get on with things here. Okay. People have been speaking to you very eloquently. I'm just going to try and summarize because their voice is actually more resonating than mine. So we know that ATTR amyloid is a genetic disorder. That's if you have the familial form, or a sporadic event if you've got wild type. But in the end, both kill. So it's a devastating disease regardless of its origins. FAP is a progressive neurologic debilitation. We've heard eloquently about it, perhaps in more ways than we can really grapple with today. It's devastating for the afflicted, as we've heard. There's loss of independence. There's guilt of passing on a devastating process to others in the family. It's clearly overwhelming for caregivers. This is a process that takes a whole family to town. It's terrifying for the subsequent generations, as Sydney has so poignantly told us. Over a 24-month study of a placebo-controlled process, I watched young men progress from jogging to canes, and older people go from cane to walker, or ultimately to wheelchair. Houses are remodeled, families are displaced. Retirement funds are exhausted, as we've heard. It's no bargain having TTR cardiomyopathy. It too has its dramatic limitations of function and life. Improved diagnostics will certainly lead to earlier and younger disease identification. The problem is going to grow over time. End organ damage, nerve and heart, is irreversible at this point, although there is some light potentially in London on the SAP disrupting agents. Autopsy data and census projections predict enormous medical systems demands. The success of early trials will reveal the true prevalence of disease, something we don't know at this point. Physicians are going to look when they are understanding that there are therapies available. Until then, it may not be on their radar screen. We're at the crossroads of disease management. The importance of early intervention has been pointed out multiple times. We need better diagnostics. We need more sensitive disease biomarkers. Pharma is focused on drug development, and we're very lucky to be the recipients of that attention. The critical elements are in place. We have knowledge, interest, innovation. The timing is right for partnering with the FDA, and doing so will accelerate development of diagnostics, access to new drugs, and hopefully together improve lives. Thank you very much.
Dr. Goldsmith, some summary remarks, please. Thank you.
So we come to the end of a very interesting day, filled with lots of important information brought forward from the medical community, from patients and families, from the regulators even today. And we didn't hear from regulated industry, but I know they're here and they are listening. I want to, let me get this right. I want to recognize the thoughtful, hard work by the ARC, investigators, patients and families, and other stakeholders in preparing, presenting, and organizing today's meeting. There were brave, courageous, frank, and eloquent presentations by patients and caregivers, and they're much appreciated. They bring home the message that all of you live with every day, but makes it clear to the rest of us as physicians and as regulators what it means to have amyloidosis. I also want to thank the participation of my colleagues from the Food and Drug Administration from the review area. It's a pleasure to have them here and have a chance to interact with the patients and families and the investigators. As you know, amyloidosis is a rare disease. And as a rare disease, it happens to be one that's progressive, serious, life-threatening, and there's a lack of approved therapies, as we've heard. The natural history of amyloidosis, I think, is better understood than it was 20 years ago, but there's still areas for further characterization to help understand what's the natural history of the disease versus the impact of a candidate drug, for instance. In trying to develop drugs, we are confronted with small populations. Small populations restrict drug design and replication, certainly. If there were a drug that went through a developmental program and had a smashing study and was licensed, that trial would never be replicated, as you know. That would be it. It would be in the market. There's phenotypic diversity. We heard lots of different stories and different perspectives of people, and even though the genetic defect might be the same, the phenotypic manifestations may differ, and it does complicate drug development. We've also heard about outcome measures, the potential use of biomarkers, and we also, from a regulator's point of view, we deal with the issues of lack of precedent. Common diseases at the FDA have been reviewed many times. If the indication was for treatment of asthma, for instance, we've licensed many drugs like that. And the people who do review have a certain way that they do this. And you heard Dr. Woodcock talk today about HIV disease and how we've incorporated some of these changes over time. But in rare diseases, and particularly in amyloidosis, we don't have a rut in the road. This has to be developed as you move forward. We've heard today about scientific and medical understanding of AL and ATTR, forms of amyloidosis and their pathophysiologies and recent advances. And we heard from Dr. Woodcock, who's the director for the Center of Drug Evaluation and Research earlier this morning, and her thoughts on this matter, which I think are very positive and forward-looking. We've also heard the patient's voice about the impact of the disease on their lives and their perspectives on therapies and potential benefit and the urgency for therapies. That message is loud and clear. And we need to continue to hear your voices. to help us understand about issues like your risk tolerance. We're allowed to have drugs under review where there's high risk if we understand that the patient population is willing to undertake those risks. So we need to hear that from the patient voice as well. I would say that we're pleased to see the increased scientific interest in amyloidosis. There's even a symposium at the American Society of Hematology this year, I noted. We're looking forward to the next steps taken by the ARC, including the development of a guidance document that they plan to share with the Food and Drug Administration, and to develop a biomarker qualification program that will also come under the review of the Food and Drug Administration. So in closing, I would like to thank you for including the Food and Drug Administration as part of the proceedings today. We've had our ears open. We're glad to hear what you had to say. It strikes my heart. I mean it. And we will look for every way possible to try and bring things forward in as timely a manner as possible. So thank you again. How about that?
That might be beyond me. Thank you so much, Dr. Goldsmith. What really struck me today is that 3 minutes to hear a story that lasts for generations. We had 3 minutes to hear the burden of disease that is every day for families and caregivers. In 3 minutes, we heard what it's like to live for a lifetime with Damocles' sword hanging over your head. And you know what? In 3 minutes, we were all deeply moved. But that doesn't even scratch the surface, truly, of what it's like to live with this disease. But what we heard are the real stories that paint the picture that the Kaplan-Meier curve doesn't tell. And it really drives home why we have to move beyond survival as an endpoint. We did also hear a few moments of hope, and I was asked if I would touch on my story. The reason that I'm so passionate about this in care is because I'm a patient. I was diagnosed with AR amyloidosis 20 years ago. I was incredibly sick when I was diagnosed. I had multiple organ involvement and was given 3 to 6 months to live. I was very fortuitous and was able to take part in one of the first stem cell transplants in the program at Boston University, which is mentioned a lot today. And it was a window in time, because if I turned up now, I wouldn't be eligible for that program in the state I was in. But what I show is that it is stoppable, and you can go on, and we can cure this disease. Patients can do well. There really is hope. And the only thing I can say is that I have the kind of health that I don't think about. So I'm a great believer in looking forwards and finding solutions and affecting change. And that's really at the core of what the Amyloidosis Research Consortium is about, and drives us so hard to be a solutions-based organization. And as I look around, I see we have representatives from all areas, literally from bench to bedside. And together we can and we need to change the outcomes. We need to develop treatments that address patients' needs, to design better trials, to effectively evaluate therapies in a timely manner, to identify and develop tools that support the evaluation, and we are committed to doing that. Today was a unique event, but also just one of the many steps in engaging and collaborating with the FDA and other stakeholders to develop a pathway to facilitate the development and evaluation of promising therapies in amyloidosis. Today was vitally important. By including the patient voice, we're making sure that we're on the right course. We are setting our true north. I really want to thank all of you from the FDA who've participated today, and I'm really heartened by the excellent turnout. And you also really for your instrumental support in setting up this meeting. And Dr. Goldsmith, rest assured you will continue to hear our voice. I'd like to also to thank the Amyloidosis Foundation and Amyloidosis Support Groups, in particular Mary O'Donnell and Muriel Finkel, on all the efforts to get this meeting, and I really look forward to an ongoing commitment and jointly serving the needs of patients. And again, I'm so thankful for the industry representatives who are here and have working so closely with us to make sure that we are reaching the patients and designing the therapies and serving them in the ways that they need. And likewise, to the amazing physicians that we have. We're really blessed in this disease to have such extraordinary physicians who have dedicated their lives to looking after us and to finding the treatments. And in particular, Dr. Gertz and Dr. Comenzo for being outstanding Rottweilers and timekeepers and just fantastic facilitators. So thank you very much. So lastly, to get down to business, if you have any of those little boxes left, give them back, because otherwise I have to pay for them. And as far as the parking, if anyone has parked, you can get a little sticker or thing at the back desk, which will give you the rate that we have. So thank you really, one and all. And really, for the patients, I'd just like to say it's been so touching to see how open you've been and the vulnerability you have showed and the commitment to sharing your stories for better outcomes. And we're here to do that and to help with that. So thank you very much.